For your patients with hard-to-control hypertension, are you struggling to achieve blood pressure goals despite treating with at least 2 antihypertensive medications? Uncontrolled hypertension increases the risk of death and stroke for many patients. Not all hypertension is the same. For many of these patients, you may want to consider a different pathway. Aldosterone may be to blame. Visit blamealdo.com to learn more.
Big news, cardio nerds! AHA Scientific Sessions 2025 is now 4 full days. Get more late-breaking science, immersive learning, and meaningful connections. Don't miss core cardiology programming, 21 education communities, and guideline-focused sessions. November 7th through 10th in New Orleans. Register now at scientificsessions.org.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Welcome, cardio nerds. This is Naima Maqsood. I'm so excited to be here with you today for another episode in our atrial fibrillation series. Today, our episode will focus on the acute management of atrial fibrillation. I'm here with Dr. Kelly Arps, an early career electrophysiologist at the University of Michigan, also the co-chair for the series. Hi, Kelly.
Hi, Naima. We are also here with episode lead and member of the CardioNerds Academy, Dr. Jake Roberts. Jake is a third-year internal medicine resident at UCLA Medical Center in Los Angeles. He earned his medical degree at Johns Hopkins University, and he will be returning to Johns Hopkins for cardiology fellowship. Welcome, Jake.
Thank you, Kelly. I'm excited to be here today and can't wait to get started with this episode and learn from an expert in the field of electrophysiology and arrhythmia management. I have the great privilege of introducing our guest expert today, Dr. Jonathan Chrispin. Dr. Chrispin is an associate professor of medicine in the Johns Hopkins Medicine Division of Cardiology, Electrophysiology, and Arrhythmia. Dr. Chrispin earned his medical degree from Vanderbilt University. He then completed his internship and residency training in the Osler Internal Medicine Residency at the Johns Hopkins Hospital, where he then completed his cardiovascular disease and electrophysiology fellowships, serving as the Chief Clinical Cardiac Electrophysiology Fellow. Dr. Chrispin currently directs the Ventricular Arrhythmia Research Program at Johns Hopkins, with a focus on advanced cardiac imaging to better understand the structural substrate associated with the development of ventricular arrhythmias. Dr. Chrispin, welcome to Cardio Nerds.
Thank you. Thank you for the introduction. It really is an honor to be here today to talk to you about acute management of atrial fibrillation. It's incredible to see what the CardioNerds has become over the years. It really has evolved into an incredible resource for physicians throughout the world. So thank you again.
Yes, thank you so much for being with us today. To get things started, we'll start out with our first question. This first question will center on the conceptual framework for the acute management of atrial fibrillation. Dr. Chrispin, to learn more about your clinical approach, let's talk about a patient presenting to the CardioNerds emergency department. This is a 65-year-old man with obesity, hypertension, obstructive sleep apnea, and prediabetes who presented for evaluation of worsening shortness of breath and palpitations. The patient has no known history of heart disease. Telemetry on presentation shows atrial fibrillation with ventricular rates elevated to 130 to 140 beats per minute. Dr. Chrispin, what would be your initial approach to addressing the acute management of atrial fibrillation in this patient? And what are some of the major considerations in your initial history taking and chart review?
Oh, this is a great question and a very common clinical scenario that we see. You may know atrial fibrillation is the most common chronic arrhythmia there is in the world, and it gets more common as we get older. And so the patient you sort of describe is sort of a typical sort of individual you see who's 65. A few comorbidities include obesity and hypertension, as well as OSA, always have been associated with atrial fibrillation. So the first thing when I encounter with a patient like this is really doing a really thorough history to kind of get a sense about the onset of their symptoms. Is this something acutely that the patient presented just a few hours ago? They were feeling fine and now they are acutely short of breath, or they feel like the heart racing rapidly? Or is this more of a subacute process that's been going on for a number of weeks? The reason for that sort of this distinction is to kind of determine, what is really sort of the driver for their atrial fibrillation and for their presentation with their rapid ventricular response. Is it sort of a lone AFib episode itself? Is it triggered by some other disease process, whether it's a cardiac condition or non-cardiac, like an infection? And so getting a really thorough history about the timing, the sort of symptoms they've been experiencing, as well as doing a pretty thorough review system to get an idea of what the next steps should be in the management And then, really important thing that I think about always first is stroke prevention and thromboembolic prevention. So, if there are any sort of contraindications to being on a blood thinner, because I think when we're thinking about these sort of patients, and we'll talk a lot more about this throughout the course of this podcast, early rhythm control, I think, will be important, but that'll be predicated on whether you could safely anticoagulate this individual.
Wonderful. Thank you so much, Dr. Chrispin. I think it's super helpful, these points you've made about, trying to clarify the exact timing of when symptoms may have started, as well as potential triggers for the considerations in our management. Of note, this patient really had no prior diagnosis of atrial fibrillation. How would your initial evaluation be different for patients who have a new diagnosis of atrial fibrillation compared to those who do have a prior history of this arrhythmia?
Yeah, it's a really important question. And especially when we're thinking about atrial fibrillation, we're trying to determine, once again, the acuity of the onset, as well as the type of atrial fibrillation. Is this somebody who has paroxysmal episodes? So maybe they present me to the emergency room now, but when you do a history, they tell you, oh, I've had these sort of similar episodes that have been going on for the past few months or over the course of the past few years. I sort of just self-terminated. But, I came to the emergency room this time around because it didn't go away versus somebody who may have persistent atrial fibrillation and may have a known history of atrial fibrillation, and they've actually been in atrial fibrillation for a very long time. And why this is important is somebody who's coming in, particularly with ventricular rates that are going pretty fast, 130 to 140 beats per minute. It sort of tells you a little bit different about what's the underlying, pathophysiology of their acute presentation. So, for example, somebody who has a history of long-standing persistent atrial fibrillation or permanent atrial fibrillation, meaning that they're just in it all the time, and there's never been a trial or any sort of rhythm control trial has been abandoned. Like somebody's coming with RVR all of a sudden makes you think, is there some other process that's driving their fast heart rates? Somebody who has persistent or permanent atrial fibrillation, when I see them coming now with RVR, I kind of actually consider it sort of like sinus tachycardia. Somebody comes in with sinus tachycardia, you wouldn't acutely try to lower their heart rates. You would try to figure out what's the underlying driver for their elevated heart rates. So similarly, somebody who's always in atrial fibrillation, you get a history that they've been in it, persisting for a very long period of time, and now they've been well rate controlled in the past, and now they're coming with a rapid ventricular response. Then once again, you're trying to figure out, okay, what is the underlying reason for their acute rapid heart rates? And then you're going to go down toward things like, are they in heart failure? Are they having an acute infectious process? Some new valvular disease that's sort of manifesting now. And so that sort of drives the decision making about what the next steps will be. Versus somebody who has newly diagnosed atrial fibrillation, then they're coming with a rapid ventricular response. They may not be on any sort of rate controlling agent. This is something that's new for them. And so that's the way I sort of approach it a little bit differently in that situation.
Awesome. Thank you so much, Dr. Crispin. That's actually a very clear delineation of how you would approach someone with, permanent or persistent atrial fibrillation versus someone that's having new paroxysmal atrial fibrillation. Looks like our patient fits into the second category. So thinking about this patient in particular with a ventricular rate of 130, 140 beats per minute, I guess our initial evaluation will be focused on making sure there aren't any additional comorbids that are, playing into their initial presentation. What would be your heart rate goal for each of those scenarios? Say you find a specific issue, like there's new onset heart failure or like a thyroid issue that's driving the initial atrial fibrillation. What would be your heart rate target then versus you don't find any just great etiology of the AFib and this is just a new diagnosis? What would be your heart rate goal and how would you approach that?
Yeah, so somebody who's coming in with atrial fibrillation and you feel like it's due to some other disease process like an infection or worsening heart failure, then I think the primary thing you should do is focus on, treating that underlying condition. So if they are, have some thyroid dysfunction, you're treating that to become with heart failure. Then you're diuresing them and you're putting them on appropriate medications to manage their heart failure. And or they're having an infectious issue, then you're giving antibiotics, giving IV fluids. And once you do that, then you kind of see where the heart rate settles out before deciding, okay, maybe I should put them on some sort of rate controlling agent to get the heart rate a little bit slower. The primary reason to do so would be just more for symptom relief. You know that when patients are going faster, the hearts are going much faster. They are symptomatic just from that alone. But once again, if it's due to an underlying disease process, my recommendation would be just to treat that underlying process and see how the dust settles after you do so and determine what the next step should be in terms of a rate versus a rhythm control strategy. Versus somebody who's, been coming in and atrial fibrillation actually is their primary diagnosis, and that's the reason why they're in the hospital. Then I think getting their heart rates under control, typically with a goal of less than 100, 110, I think is sort of reasonable in sort of the immediate sort of setting. And there has been, one sort of major clinical trial that looked up into this. This was the RACE 2 trial where they compared lenient versus strict rate control, with strict rate control being less than 80 beats per minute and lenient less than 110 beats per minute. And they found there was no difference between those two groups in terms of some hard outcomes of mortality, hospitalization for heart failure. So because of that, the primary reason to get the heart rate better controlled, once again, would be for more symptom relief as opposed to some other long-term sort of mortality benefit or even some sort of heart failure rate based on that one study. But in my experience, when patients do come in with atrial fibrillation rapid rates, oftentimes it's the rapid rate that's causing them to feel short of breath, to feel fatigued. And then once you get the heart rate better control, even if they are in atrial fibrillation, then a lot of their symptoms are resolved. And then in terms of the time course to do that, I don't think you need to acutely get somebody's heart rate from 140 to 90 beats per minute within a couple hours, unless there's some other sort of mitigating factors. Even when they did these sort of clinical trials, this was done over days to weeks in terms of reassessment of their heart rates. So unless there's some other process that you worry about, worsening heart failure, decompensated heart failure, or they're just hemodynamically unstable, and then at point you're thinking about acute sort of cardioversion, think getting the heart rate under control over or even days, I think is reasonable. What you don't want to do is slam somebody with a lot of nodal blocking agents. They become bradycardic or hypotensive.
One of our challenges to try to sort out whether their atrial fibrillation with RVR is related to the rhythm itself or more related to an underlying diagnosis, as you highlighted. And things get even more complicated, essentially, the sicker the patient gets. For instance, a patient with septic shock or GI bleed and hypovolemic shock. And we often find ourselves trying to figure out how to balance that patient's natural heart rate response with the potential instability that is being made worse by that. How do you think about those situations?
Yeah, certainly it's a very complicated situation. And, there's sort of not just one sort of approach for all. But I do think feel very strongly that if somebody comes in, for example, with decompensated heart failure, and their heart rates are going really fast, then your focus is on, making sure they're getting to a volume status to where they need to get them evolemic. If they are having sort of a low output sort of state, that is sort of a sign of acute hemodynamic instability. Their lactate is going up. If they're not perfusing very well and their heart rates are going 140, 150 beats per minute, then in that situation, it would be reasonable to consider a cardioversion to just eliminate the atrial fibrillation rapid rates as sort of contributor to their decompensation. I do find that, once you do treat a lot of these patients, so for their heart failure, the heart rate certainly improves a little bit. And once again, you don't want to get them to a heart rate of, 70 or 80 beats per minute. They do still need that elevated heart rate to help improve their cardiac output. But it's a challenging thing, and oftentimes, these individuals may end up in the ICU, and whether you're putting a swan to kind of help guide some of the therapy, or whether it needs inotropic support. But in setting where there's, lack of perfusion or decreased perfusion based on looking at once again their blood work, their labs, looking at their cardiac output, in that situation, it would be clearly indicated to do a cardioversion, once again, to eliminate the AFib as a contributor to their acute decompensation. Somebody who's infected, I think similarly, I focus more on, fluid resuscitation, antibiotics, and not try so hard to focus on rate control in that particular situation. Now, once they are, their fluid status is back to where you think it should be, and they've been on appropriate antibiotics and their heart rates are still going fast, then I think judiciously you may introduce some nodal blocking agents to kind of get the heart rate to a little bit better control. Once again, primarily to help improve symptoms. But if there is a concern, and sometimes you don't know until you actually do a cardioversion, certainly is reasonable to do so in somebody who is acutely decompensated and they're having hemodynamic instability. It is important that when you start thinking that sort of strategy about, what is the long-term anticoagulation plan, whether somebody has been atrial fibrillation for, days or weeks, and have they been appropriately anticoagulated? If not, then you're also weighing the balance of, thromboembolic events when you do acutely cardiovert somebody. And so when you're thinking about that sort of thing, obviously with an emergency, you'll do it. But you also have to think about, ruling out a left atrial appendage thrombus in your situations, making sure what's the anticoagulated plan. And so all these sort of factors are kind of weighing your decision about what to do when something comes in with AFib with RVR.
Yes, absolutely. And now I want to segue back to those patients who we were talking about earlier who do come in with a primary diagnosis of atrial fibrillation and have an indication for acute rate control while we determine the long-term plan. We know that choices for these rate controlling medications include both IV and oral formulations of beta blockers and calcium channel blockers and maybe occasionally digoxin. So, can you discuss with us your medication strategy for rate control and what considerations you make when deciding between one or multiple of these medication options?
And so certainly, as you mentioned, beta blockers, non-dihydropyridine calcium channel blockers are sort of the mainstay of therapy for rate control. The choice between the two will depend on whether sort of comorbidities are present, whether somebody has heart failure, getting an echocardiogram to make sure they don't have poor LVEF. In those situations, you want to avoid a lot of these medications, but in particular the calcium channel blockers. In my practice, typically I kind of lean more towards beta blockers, just because oftentimes a lot of our patients have indications for being on a beta blocker outside of just atrial fibrillation, whether it's because they do have heart failure or coronary disease. Diltiazem is sort of a reasonable choice for somebody who has a preserved LVEF and you're not concerned based on your physical exam that they are in heart failure or at least not having kind of a low output heart failure. That would be sort of a reasonable one to choose. Digoxin is another agent to kind of keep in your back pocket. I use this sparingly, typically in patients who are in heart failure where you're unable to initiate a beta blocker or calcium channel blocker because of their low ejection fraction, because of hypotension. Then this would be not an unreasonable choice, at least in the acute setting, to get some rate control, get some positive inotropy as well to help control the rate. Typically, I don't favor it as a great long-term solution for rate control. Oftentimes, because you do have to monitor them pretty closely, you have to monitor their levels, and I find that sometimes that gets dropped when patients get discharged to the hospital and people are not following their digoxin levels. And then you can get yourself in trouble down the road, especially if they develop kidney dysfunction post hospitalization. And then for those who can't be on a beta blocker or a calcium channel blocker, just because of hypertension or heart failure, maybe they have some renal dysfunction, and so you don't want to put them on digoxin, then the guidelines would say that amiodarone would be a reasonable rate controlling agent. For our listeners, I think you should do so carefully because you can convert somebody with amiodarone. And so once again, if they're not properly anticoagulated, you do run the risk of, causing or precipitating a thromboembolic event if they do cardiovert. And so before putting somebody on amiodarone for rate control, once again, you really need to make sure that they are appropriately anticoagulated. And if they haven't been prior to initiation of the amiodarone, then you want to rule out a atrial appendage clots, either with a transesophageal echocardiogram or oftentimes we actually use our cardiac CT in our center to rule out clots. And so once again, so beta blockers, calcium channel blockers are the main agent. For those who have heart failure or low ejection fractions or who are hypotensive, you may consider digoxin as well as an amiodarone.
Great. Thank you so much for that discussion, Dr. Chrispin. We've discussed a lot about sort of these rate control strategies, and I know you touched on a little bit in terms of some scenarios in which rhythm control may be more of an optimal upfront strategy. To expand on that, can you kind of share with us more about what kinds of patients or clinical scenarios may lead to a more stronger consideration for upfront rhythm control once these patients are safely anticoagulated? For example, those patients who may have more of a mixed shock picture due to underlying advanced cardiac disease, such as restrictive cardiomyopathy, diastolic dysfunction, or amyloid, where the atrial systole may be more important for those patients, as well as others with constrictive physiology and valvular disease like mitral stenosis.
Yeah, so certainly I know the topic today is for acute management of AFib, primarily with rate control. But I always tell all my fellows and the residents that the best form of rate control is rhythm control. And so, as an electrophysiologist, honestly, every patient that I see with atrial fibrillation, my thought process is the default is rhythm control. Then are there reasons why rhythm control strategy would not be appropriate in an individual? There's more and more data showing that rhythm control is probably better for most patients, especially heart failure patients, but people just in general as upfront strategy for the management of atrial fibrillation. And so, once again, my approach is really, who is not a rhythm control candidate. In terms of the acute setting, sometimes you may be limited in terms of what you can do acutely, but the things that you have to do rhythm control are cardioversions, either pharmacologically or electrically. In some of your examples, just say somebody coming in with heart failure, they have new onset atrial fibrillation, or maybe been in atrial fibrillation for some time, and you want to get back into normal rhythm. I have a low threshold for performing a cardioversion in those individuals. Oftentimes, I would actually put them on some sort of antiarrhythmic drug. So that way, when you do the cardioversion, they're more likely to stay in normal rhythm for the cardioversion. Outpatient follow up to kind of talk about long term solutions about either the antiarrhythmic drugs or what they want to finish in the more invasive procedures like a catheter ablation for long term rhythm control to help improve the burden of atrial fibrillation overall. And so to your question about, when do you want to consider an upfront rhythm control strategy? I would make the argument that everyone should have an upfront, at least thought or discussion about rhythm control. For those who there's some other sort of acute process, whether it's a malignancy or some other process that makes long-term rhythm control strategy not an ideal situation, then you want to pursue rate control with those individuals.
Awesome. Thank you so much for that great discussion, Dr. Chrispin. We have a good idea of how to manage our first patient. So now we're going to move on to our second patient in the CardioNerds emergency department. This patient is a 58-year-old woman with a history of heart failure with reduced EF, presenting to the ED with progressive lower extremity swelling and shortness of breath. She has a previous diagnosis of paroxysmal atrial fibrillation, and her most recent echo demonstrated an LVEF of 35%. The patient is found to have bilateral lower extremity pitting edema to her knees and elevated jugular venous pressure, and she's required 2 liters of oxygen by nasal cannula. She is in rapid atrial fibrillation as well. Interrogation of her primary prevention ICD shows that she has been in AFib for the past 3 weeks. So specifically in this scenario, Dr. Crispin, in a patient with acute heart failure, when would you, and specifically because we talked about at least trying or thinking for a more upfront rhythm control strategy, when would you consider electrical cardioversion in this patient, even specifically if after doing an initial trial of beta blocking and diuretic therapy, the patient stays in atrial fibrillation?
Yeah, so definitely in this situation, an upfront rhythm control strategy is definitely indicated and something to do before they get discharged. And so in this situation, she's coming with heart failure symptoms. Doesn't seem that she's in, shock. And so maybe you are trying to gently rate control her with some beta blockers. But ultimately, especially given the fact that she's been in this rhythm for the past 3 weeks, cardioversion, either chemically or electrically, is going to be indicated. When I see these sort of consults in the hospital, one of the first things that we talk about is putting them on an antiarrhythmic drug. Once again, I am kind of harping on this point a lot because I think it's really important. And if you look at the data, unfortunately, even cardiologists don't do a great job in terms of appropriately anticoagulating individuals. But once you address the anticoagulation status and either you put them on a blood thinner if they haven't been one already, or you continue it, then we have a discussion about not only doing a cardioversion electrically, but oftentimes, once again, as I mentioned before, I try to put them on some sort of antiarrhythmic drug because the cardioversion, if you do it electrically, it works pretty much 99% of the time, but, early recurrences can and do happen. Give the patient the best chance of staying in normal rhythm long term. We talk about putting on some sort of antiarrhythmic drug. So somebody with an LVEF of 35%, coming with heart failure, you're really sort of limited to 2 sorts of medications, either amiodarone or dofetilide. Here at our institution, we actually are very comfortable with dofetilide and we use it a lot in the situation because you kind of avoid some of the long-term toxicities associated with amiodarone, and it can be effective both acutely in terms of terminating atrial fibrillation, but also it's a good longer-term antiarrhythmic option. For those who have kidney disease, renal disease, or develop QT prolongation, or you're worried about your QT prolonging, then amiodarone would be a reasonable. I usually refer to as kind of a short-term solution to bridge the patient to a more definitive long-term strategy for rhythm control. And so in this situation, it will present her either with amiodarone or dofetilide for antiarrhythmic drug therapy. And if they don't convert with antiarrhythmic drugs, then perform electrical cardioversion, typically when they're euvolemic and after they receive a number of doses of the antiarrhythmic drug. So typically for the amiodarone, try to aim for a 5 to 10 gram load before doing the cardioversion. And for dofetilide, typically after their fourth dose, we perform a cardioversion to make sure they're able to kind of stay in normal rhythm after the cardioversion, electrical cardioversion.
And thank you so much, Dr. Chrispin. That makes perfect sense. I also wanted some clarity on, like, for someone specifically like this patient that's presenting with acute decompensated heart failure, as far as their volume status, where do you want them to be when you're planning the cardioversion?
And definitely want to be as close to euvolemic as possible. Just offloading the left ventricle, which in turn offloads the left atrium, makes it more likely that they are to stay in normal rhythm following the cardioversion. What you don't want to do is do any sort of electrical cardioversion while they're still significantly body overloaded, just because they'll be kind of early return of atrial fibrillation in that situation. And then you're most likely going to have to diurese them and BP the cardioversion down the road. So I think to give them the best chance of success, staying in normal rhythm, you try to aim for them to be as close to euvolemic as possible before doing an electrical cardioversion.
So, another context in which we often find ourselves managing atrial fibrillation is in the postoperative setting. Dr. Chrispin, can you discuss your management strategies for post-op AFib and how, if at all, this varies between patients who underwent cardiac versus non-cardiac surgeries?
And thanks for the question. This is a very common clinical scenario that we're faced with. We do appreciate that, especially with cardiac surgery, there's just simply increased risk for developing postoperative AFib, with studies ranging from 30 to 60%. My approach is kind of first centered on whether the patient has a history of atrial fibrillation prior to their surgery. This is important because when you think about what are sort of the long-term consequences of developing atrial fibrillation in a postoperative state, what is their risk for recurrence, which kind of help dictate what the next step should be. So for someone who has a prior history of atrial fibrillation, it's not going to be surprising that they develop atrial fibrillation in a postoperative state. And then you're going to treat them like any other sort of atrial fibrillation patient, where they're hopefully anticoagulated long term. After their surgery and once they recovered, you may discuss about long-term rhythm control strategies. But for somebody who has a prior history of atrial fibrillation, you're going to manage them very similarly to somebody who has atrial fibrillation even outside the operative state. And that's going to entail either rate control or preferably rhythm control to, once again, restore sinus rhythm. As we appreciate from a number of kind of recent trials, that's just early rhythm control, which is better for patients, for most patients overall, in terms of symptom relief and potentially even reducing the risk for things like stroke, heart failure. Now, for someone who has no prior history of atrial fibrillation and they develop postoperative atrial fibrillation, historically, the teaching was that this is all inflammatory. It's all happening in a postoperative state. This is kind of a short-term issue, and it shouldn't have any, long-term consequences. There are some, more recent data that are questioning that. It's not surprising that if you develop atrial fibrillation postoperatively, then it's more likely to recur down the road, even outside the surgical sort of setting. But our current sort of approach and guidelines is that you anticoagulate individuals if they have a high enough mass score for at least 60 days postoperatively. And then you monitor them afterwards to determine whether atrial fibrillation persists or whether it just goes away, and determines whether you're going to think about more long-term rhythm control or rate control strategies. Acutely, I think it's still preferable to get people back in normal rhythm. There's some data, especially in the cardiac surgery literature, that restoring sinus rhythm, something that develops post-operative atrial fibrillation, plus improves just long-term outcomes in terms of rehospitalizations and heart failure, and potentially even some mortality data. And so our preference is to get them back into a normal rhythm if they're able to tolerate anticoagulation. Now, that may be an issue depending on the kind of surgery they had, that you're not able to put them on anticoagulation. If that's the case, then rate control would be the preferred strategy. It really don't make a big difference between whether it's cardiac versus non-cardiac surgeries. We do know the event rate for postoperative atrial fibrillation will be higher amongst those who undergo cardiac surgery. But in terms of the way we treat them, I think it's very similar, whether it's cardiac versus non-cardiac. And so once again, the decisions first, rate versus rhythm control, with a preference for rhythm control to get them back into normal rhythm with the cardioversion. And then you plus minus putting them onto our antiarrhythmic drug during the 30 to 60 days post the cardioversion to help maintain sinus rhythm. And if they have no prior history of atrial fibrillation, potentially doing some surveillance afterwards to make sure that atrial fibrillation does not recur. But for those who have a prior history of atrial fibrillation, you'll continue to manage and treat them like you do any other patient with atrial fibrillation.
Wonderful. Thank you so much for all of that great discussion, Dr. Chrispin. So far, our focus is mainly centered on managing those patients who require an acute hospitalization for the management of atrial fibrillation. However, we would now like to shift our focus towards those patients with a known history of paroxysmal atrial fibrillation who are trying to avoid recurrent acute care presentations. One of the approaches we often hear about but may not often see in practice is the use of a pill in the pocket strategy for those patients who experience infrequent episodes of symptomatic atrial fibrillation. Dr. Chrispin, could you tell us more about the patient selection for these strategies, the medications most often used, and the potential benefits and drawbacks of this approach?
Yeah, you're correct in that we often hear about the pill in a pocket strategy, but it is frequently used in clinical practice. To be upfront, in my personal practice, I almost never use a pill in a pocket approach. I think part of it is that you want to avoid atrial fibrillation from happening in the first place. And so a pill in a pocket approach, you keep it to the fact that atrial will happen. And so you're just trying to terminate when it does occur. I probably some other podcasts will talk more about management of the ablation procedures for management of atrial fibrillation, and certainly patients who have recurrent episodes of atrial fibrillation, that may be a better kind of long-term strategy. But for those who do want to do this pill in the pocket approach, typically it's done with a class line. So to think like flecainide or propafenone. It is important to actually do this in some sort of monitored setting when you first try a pill in a pocket approach, because you are giving a much higher dose of the antiarrhythmic drug. For example, like flecainide, you may give up 300 milligrams at one time. Or typically, when you're starting a patient on a drug like flecainide, you're starting at 50 to 100 milligrams twice daily. That's sort of a maintenance dose. And so to make sure they don't develop any sort of acute toxicities to this high dose of drug, it should be done in a monitored setting first, and one, to see if it's effective, and two, to monitor them on with the telemetry and on ECG to make sure there's no acute toxicity that you're causing. Because once again, this starts to also be a very pro-arrhythmic. And so that is sort of one strategy that historically has been talked about. It's rarely used in clinical practice, especially in the advent of catheter ablation procedures, and also for the fact that you really want to avoid having AFib in the first place. And so to do so, it'd probably be much better to be on some sort of maintenance antiarrhythmic drug.
Thank you. That's definitely a great and helpful discussion of that strategy for us. Dr. Crispin, thank you so much for all of your excellent teaching today about the management of acute atrial fibrillation. In particular, my favorite takeaway from this episode was that the best form of rate control is rhythm control. With so many incredible learning points discussed today, what clinical pearls do you hope all cardio nerds will remember?
Yeah, so I think the first thing to really focus on is thromboembolic prevention. And so when you first see your patient with atrial fibrillation, I think that's kind of running your mind in parallel to other sort of clinical decision making is, what is your stroke risk and are they on appropriate anticoagulation? Because I think that's sort of the biggest thing that we can improve on as a healthcare community to help reduce the morbidity fatality associated with atrial fibrillation. And so the first thing is stroke prevention, thromboembolic prevention, making sure people are appropriately anticoagulated. And as you mentioned, rhythm control is the best form of rate control. I do think that for most, rhythm control should be the default sort of option. And then it's really you're trying to find a reason for them not to have undergo a rhythm control strategy when they present with atrial fibrillation. And so while in an acute setting, you may give some little blocking agents or rate controlling agents to help control the rate, the ultimate strategy would be to get them back into a normal rhythm, unless the patient prefers not to undergo strategies with antiarrhythmic drugs or cardioversion to restore sinus rhythm, or there's other sort of medical reasons that a rhythm control strategy wouldn't be appropriate in that situation. And so I think the mindset of, once again, making sure people are appropriately anticoagulated and finding ways to restore sinus rhythm, I think will do our patients great service.
Thank you so much, Dr. Crispin. One last question. This is something we ask all CardioNerds guests. What makes your heart flutter about treating patients with arrhythmias?
Well, I think it's probably the cardio nerd in me that actually just enjoys the physiology of arrhythmias. I do love sort of the detective work that we do for some of our tech arrhythmias that we treat in the EP lab, trying to figure out what the diagnosis is, figuring out the mechanism, and then figure out where in the heart we actually can do the ablation to restore sinus rhythm. And most importantly, it's just for patient satisfaction. It's really rewarding to help patients who are debilitated by their arrhythmias, either by restoring sinus rhythm, by treating atrial fibrillation or PVCs, preventing ICD shots with ventricular tachycardia ablations, or just treating patients with pacemakers and defibrillators to help improve their quality of life or decrease the risk of sudden cardiac death. And so it's for all those things, a variety of cases that we see that really got me into the field of electrophysiology, and I want to change it for the world.
Well, on that note, thank you all for joining us today. Thanks in particular to Jake for preparing this episode and to Dr. Chrispin for taking the time to really share his expertise with us.
Thank you very much. It really was a pleasure and honor to talk to you today, and hopefully the audience learned a point or two about treating atrial fibrillation.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Bhavya Shah. I'm an intern in the CardioNerds Academy House Eindhoven and a fourth-year medical student at Rowan Virtue School of Osteopathic Medicine. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.